Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Well, welcome everybody again to another episode of our show, bringing you another really fascinating guest today, helping to create a better tomorrow. Today we have the honor of being joined on the show by Dr. Rosamund Lewis, who is currently head of the World Health Organization's Smallpox Secretariat, Emerging Diseases and Zoonosis Unit, a part of the World Health Emergencies Program located in Geneva, Switzerland, where she leads on emergency preparedness and advising on health security for the agency in this extremely critical domain. Previous to this role, Dr. Lewis joined the World Health Organization COVID-19 response team, and there she was health science lead for the management of infodemics, which is another topic we'll be getting into. A public health physician with an early career in both family and emergency medicine, Dr. Lewis has served the World Health Organization, the Government of Canada, the Ottawa Public Health System, and other agencies at global, national, and municipal levels in emergency preparedness, health security, disease surveillance and response, offering support for a range of immunization and disease control programs. She's also been involved in other roles focused on field epidemiology and emergency settings with organizations like Doctors Without Borders, as well as the development of new vaccines and health systems with organizations like the Global Vaccine Alliance. Along with her Bachelor's of Science and medical degree from McGill University, Dr. Lewis also holds a Master's of Science in Epidemiology and Biostatistics, a Master's of Management and Health Leadership, and fellowships in family medicine and public health and preventative medicine, and she has published extensively in various areas of her work. She also holds an appointment as adjunct professor in the School of Epidemiology and Public Health at University of Ottawa. We are honored to have her with us today. Dr. Rosamund Lewis, thank you so much for taking the time out of your schedule to come talk with us.
Hello, Ira. It's such a pleasure to be here. Thank you so much for a kind introduction.
Yeah, it's really great having you, and you know, obviously for us that have been watching sort of current news in the recent months with the monkeypox outbreak, we've seen you on the international press. But for the rest of the audience that may be little less familiar with you, could you take a couple of minutes and just talk about sort of the early days, a little bit about where you grew up, how you got into medicine, and ultimately a little bit of your journey into epidemiology? I think that'd be a great way to start things off.
Sure. Well, thanks very much. I come from a multicultural background in some ways. I called myself an invisible immigrant, an inaudible immigrant to Canada because my parents were English, and I was born in France and then moved to Canada and lived both in Ontario as well as Quebec. And so ultimately ended up, from my very linguistic parents, learning and operating in both English and French. So that was my background. As to you know, my interest in medicine, well, I'm one of those lucky people that developed a vocation very young. I can see now that for young people it's not easy, and there are many jobs out there to choose from. I did think by the age of 7 or so that I wanted to be a doctor, a physician, and by the age of 17, I thought, well, I want to be a doctor in Africa. And it's a bit mysterious where all this came from. There were no physicians in my family, and so there it is. But even you know, quite early on, already in my 20s, I kind of cottoned on to what was the World Health Organization, and had the opportunity to visit the headquarters, and I thought, oh, I'm going to work there one day. But I preferred a circuitous route. And so I preferred, you know, working in clinical medicine. I had a vocation for public health, but then I also wanted to work with Médecins Sans Frontières. And so I did all those things. And here I am today, back where I actually started some years ago, but I did another detour in between, back at the World Health Organization in the emergencies program, which I think is my home now.
Oh, yeah, most definitely. Most definitely. And looking at your, what I'll call your infectious disease portfolio to date, at least prior to the Secretariat, the Smallpox Secretariat. I mean, you've had to manage one disease after another of all the nasties, I'll call them, from malaria to measles, H flu, polio, Lassa, and I've had people on the show from the, here in the United States in the Epidemic Intelligence Services for the CDC, which, who gets sent off to interesting parts of the world to manage things. Could you talk a little bit about, because, I went through a lot of your publications and, whether it was managing meningitis outbreaks in Togo or Lassa studies in Guinea. Talk a little bit about sort of some of those days and your experiences of when, you got that phone call and they said, okay, Rosamund, I need you in Guinea in 3 days. The plane will be waiting for you. Go take care of X. Talk a little bit about some of those early days and how the portfolio was chosen for you, let's say.
Well, I think the portfolio chose itself. I had 2 vocations were at the complete opposite ends of the spectrum. On the one hand, I wanted to be an emergency physician. On the other hand, I wanted to be a public health specialist. And so, how was I going to do that? Well, one of the answers is infectious disease response. And I've been always interested in vaccines and immunization. And so much of my work, not all of it, but a lot of it has revolved around immunization programs and rapid response to infectious diseases, many of which include immunization, but not exclusively. It's not the only answer to infectious disease response. There are many other public health measures. But, in all of that, I still have more of a generalist bent. I'm not a virologist. I'm not an infectious disease specialist. I'm a family physician and a public health and preventive medicine physician. And so this is a much broader, it's a broader skill set. It goes wide rather than deep. And so in the choice of a master's degree, the choice of epidemiology and biostatistics was quite deliberate in the sense that I had a choice of 3 or 4 different master's degrees that I could do at the time as part of the public health and preventive medicine residency. But that one seemed to be the one that gave a toolkit that was like, well, the skills you learn in epi and biostats is something that can apply in many different areas, whether you go into communicable disease control, whether you're going to environmental health, whether you're going to health promotion, disease prevention of, chronic diseases, for example, cardiovascular diseases. The skills that you learn in epi and biostatistics are the skills that you can apply in any domain. So again, my bent was still to be a generalist as opposed to a specialist. But then once you have those skill sets and you bring them into a specific response, you have an interest in emergency response, an interest in public health, and a skill set in epidemiology and a little bit in biostats. That gives you really a good overview of what might need to be done strategically in any emergency response situation, and also very applicable in infectious disease responses. So when I joined Médecins Sans Frontières, it was out of an interest of working in the field, building skills from the ground up, really getting field experience before moving into strategy and policy, and feeling grounded in the clinician's office, feeling grounded in the emergency room, feeling grounded in a refugee camp, feeling grounded in a field setting, a variety of field settings, and that gives you the strength, the confidence, and to some extent the credibility to be able to then operate at the planning level or at the strategic and policy level.
And obviously, all those experiences have helped prepare you for this extremely important role that you have now in terms of heading up the WHO Smallpox Secretariat. And just a little background for the audience: we have this genus of viruses known as orthopoxviruses, which smallpox falls into, along with cow, horse, camel, and monkeypox, which we'll be getting into in a little bit. No, chickenpox is not involved in this. That's something totally different. And here we have, on one hand, an extremely scary disease with an extremely high case fatality rate, but on the other hand, positive, we have it has become the disease that we have eradicated. Could you talk a little bit about? So the Secretariat is called the smallpox, but you obviously doing a lot. You do a lot of other things in there. Are there still things that the Secretariat does in the area of smallpox? I know, if anyone wants to come to you and do smallpox research, you have to approve stuff and all that. What else goes on today in 2022 regarding smallpox that's interesting or that we should know about? And we'll talk about the other poxes later.
Right. So as you mentioned, smallpox was eradicated. I was declared eradicated in 1980 by the World Health Assembly, which is the assembly of all member states of the World Health Organization. And they reviewed the surveillance evidence that was presented, 2 years of surveillance. And they said, well, we believe you. We believe the technicians, the scientists, and the epidemiologists who are saying that there's no smallpox anywhere in the world. And so the World Health Assembly issued a declaration saying that smallpox had been eradicated. That was a momentous occasion for public health for all member states, all countries of the world, and the World Health Organization. And so from that time, of course, there had to be work done after that. And one of those things was that, there was virus still being held in laboratories, in many different laboratories. And these sort of collections of viruses which came from patients with smallpox. And by the way, the virus that causes smallpox is called variola virus. That's the actual name of the virus. And so these collections were reduced progressively over time for safety, for biosafety and biosecurity purposes, until there were only 2 labs left that actually retained virus. And these were the United States Centers for Disease Control and the Center for Biotechnology in the Russian Federation called Vector. And these 2 labs are the labs that have retained for the past 4 decades their collections of variola virus. And this was authorized by the World Health Assembly for the purpose of continuing research on the virus and of developing countermeasures specifically. So we had countermeasures. We had a little bit of diagnostics, not very much. Vaccine that was developed in many countries in the world and was a very potent and effective vaccine, and no specific therapeutics at all. And despite the limitations of the countermeasures that were available at the time, the world eradicated smallpox. However, there was an expressed desire by many member states to say, well, we don't know for sure. This has never been done before. We don't know for sure that smallpox can never come back. We don't know for sure that another orthopox virus can't come and take its place. There's a lot we don't know. These vaccines, in today's world would not be perfect products. Let's keep working to develop better vaccines, safer vaccines, and treatments and diagnostics with the intention of doing it for smallpox. But when you're doing the research, you have to first go through research in other pox viruses before the authorization is provided to do research with the variola virus. So that much of the research in the laboratory, in animal models, have been done actually with other pox viruses, with vaccinia, with monkeypox virus. And so when WHO finally authorizes the use of the variola virus for research, it's actually the last step. And so these 40 years essentially of ongoing research in this area has led to the countermeasures we have available today. Some diagnostics, some vaccines, and some therapeutics.
Excellent. And now speaking of other orthopox viruses, here we are in the middle of 2022. We have a current monkeypox situation, and that this is something that we've known about for a while in terms of monkeypox and Africa and so forth. You've been involved in research and epidemiology in this particular area. But on the other hand, as you pointed out, there's a recent Nature Briefing article, Monkeypox in Africa, the Science the World Ignored. We can't sit around waiting for things to get here and not deal with them properly there in the first place. Talk a little bit, if you would, just about where we are today as you and I are chatting. You know, obviously COVID is still the major theme out there, but we do see Dr. Rosamund Lewis on the TV a lot talking about monkeypox. Where are we? And can you talk a little bit about some of the themes in this Nature briefing, because I think this is very important.
So monkeypox was first discovered in 1958, actually. It was a virus found in a research lab in Copenhagen, Denmark, and it was a research lab that used non-human primates for different types of research. And so they often had nuisance viruses, and one virus then they discovered they had never found before, and they found it was an orthopox virus. It was actually then named monkeypox because the first animal in which it was found was a monkey. At that time, there were already other pox viruses identified. And then the first, so it was discovered in the animal population, but in a research lab, so a little bit unusual. But then a child was identified, confirmed to have monkeypox in the Democratic Republic of the Congo, which was then called Zaire. It was a 9-month-old child, and that happened in 1970. That first case was confirmed by our colleagues in the Russian Federation, and thereafter 2 other cases were rapidly confirmed by our colleagues in the United States Centers for Disease Control. We've always worked together with these 2 institutions in a collaborative manner because that's how smallpox was eradicated to begin with. So it's interesting times now, but the work that has been done by these 2 institutions and over the past 40 years has been to continue to elucidate, to understand better these viruses, as well as the countermeasures I mentioned earlier. But in the meantime, vaccination against smallpox all over the world was stopped in countries that hadn't already stopped. Some countries stopped in the late 60s or the 70s, but in 1980, the Health Assembly agreed that smallpox vaccination would no longer be necessary, and all countries stopped. So the global immunity that had been built up by, on the one hand, exposure to smallpox, on the other hand, use of the smallpox vaccine in many, if not all countries, began to wane over time because new cohorts of children were born, many infants who didn't have any exposure and didn't have any protection through vaccine. So now we are 40 years down the road, and during that time, monkeypox has become what we call an emerging zoonotic disease. Emerging because the number of cases continue to increase annually. New outbreaks occur. We learn new things as we go along, but investment in research in Africa has been not insignificant, but not sufficient. There's been quite a bit that has been done, especially in the 80s, to make sure that this wasn't a threat for smallpox. And there's been more we can talk about if you're interested. But the main thing is that this virus has been emerging, and it has been known to be a zoonotic emerging disease, right? So first the virus is in animals, and so it's not just monkeys. So it's very quickly realized that it occurs in squirrels, giant Gambian pouched rats, animals that live in the forest, and animals that are of interest also for hunters who look for these animals as a source of protein. They bring back the results of their hunt to their family, or they even sell it on the market. And so this virus can be sometimes present in the animals. And if you're capturing, preparing, cooking an infected animal, you may be exposed through cuts in the skin, through exposure to body fluids of the animal, or possibly through consumption of inadequately cooked meat. And these are all modes of exposure that have been well described for a long time. And what would happen is that individuals would become infected with the monkeypox virus through these types of exposures. And then because it was still infectious disease, they could pass it to people in close contact, primarily in the household setting. Not exclusively, but that's primarily the mode of transmission that has been described in the household setting through close personal contact. And then as time went on, those chains of transmission have started to get longer and longer. And this is partly because the older population groups always had immunity. But now anyone under the age of 42 in some countries and under 50 in others would not have any immunity to orthopox viruses. Right. So this allowed that, so the virus is being introduced in a setting where immunity was waning, and so chains of transmission can get longer and longer. At the same time, we have climate change, deforestation, encroachment on on forest areas which have many species in the biosphere, and also perhaps enlargement of urban areas. And sometimes some of the animals also encroach on the urban areas. And so we have this, what used to be perhaps a better separation between sylvatic forest areas and urban areas. There's no longer such a clear-cut separation. People go into the forest, animals come out of the forest, and so there is more exposure. Now, scientists have described 2 primary clades of the monkeypox virus. So what I'm talking about is something that has really been reasonably well described, at least in the early days, in the settings of Central Africa, the Democratic Republic of the Congo, Central African Republic, parts of Cameroon, Gabon. Mm-hmm. But in West Africa, it was found that there was a slightly different clade of the virus called West African clade, which appeared to be less severe. Now, even smallpox had different varieties of variola virus. There was variola major, variola minor, and here we're seeing something similar. We have a clade that causes more severe disease and a clade that has been always known to cause less severe disease. But that has a flip side. The flip side is if the disease is less severe, then there may be more contact between people who have it. Because if you have an infectious disease, but you're not feeling as ill as you might do if you had a different version of that same disease, then you continue to move around and have contact with people. So in the outbreak that began in Nigeria in 2017, that was more of that was found to be West African. It was their first case in 40 years also. The last case Nigeria had documented was in 1978. And then 2017, an outbreak of West African clade of monkeypox virus. It definitely took people by surprise. It wasn't expected at that time. They did a tremendous response, a tremendous job in responding to that outbreak, but in fact, it never went away. So what may have been happening was that there was independent zoonotic spillover events. So when we say spillover, we mean from animal populations into human populations. But because immunity was waning everywhere and because this clade caused less severe disease, it's understandable that human-to-human transmission would also occur and may continue to occur, depending on the nature of the transmission.
Yeah, you bringing up the themes of Africa and now zoonotic spillover specifically. It gets me thinking about this extremely important topic of One Health that we've been profiling on some of the other episodes. We had folks like Dr. Desmond from the Liberia Chimpanzee Rescue Group, who also does Ebola surveillance, and then Dr. Zukasoka from the the Conservation through Public Health in Uganda. She's also on the WHO SAGO, looking at the origins of the novel pathogens. Can you say a few words about just One Health as it pertains to your secretariat and the orthopox viruses, and just because in both of these discussions we had previously, obviously we talked about the spillover to humans, but Gladys also talked about the spillover the other way, that she was having hippopotamuses and other organisms that were coming down with COVID now. Can you say a few words about One Health, if you would, from the position of your secretariat? Yeah, so WHO has a One Health initiative, which is cross-cutting. So for us in the Smallpox Secretariat, we have our little contribution not from the smallpox, which was not a zoonotic disease, but from indeed monkeypox and other orthopox viruses that are out there. So we have our contribution, but One Health in general is really critically important, as you've probably already discussed. Then that the entities that are involved are Animal Health Organization, the World Organization of Animal Health, World Health Organization, and recently the United Nations Environment Program was included, the fourth member of the group. So it really is a collaboration that is critically important to provide research, scientific evidence, guidance, a place for people to discuss these issues at the policy level, to try and support countries as they do this work. In our work, it's critically important that if we're doing an outbreak investigation,
If you think that there's a zoonotic element to that outbreak investigation, it's critically important to have animal health specialists in the investigation team. And for epidemiologists, that has not been traditional in the past. Right? And, the human disease outbreak would include a communications person, an epidemiologist, perhaps a lab person to advise on how to collect specimens or to collect specimens. You wouldn't normally also include an animal health specialist in your investigation team for measles, for example. There's no reason to.
Sure.
But what we've included in our training that we've developed, there's an online training for those who are interested on OpenWHO, which is our massive open online training platforms called openwho.org. And on there, you find many different courses, but there's 2 of them in 2 languages, incidentally, English and French. There's an introductory course and an extended course on monkeypox. Those were developed and posted in January 20, they were developed over 2 years, but they were posted in January 2022, a little bit timely.
Yep.
But we've been doing these things. You'll find in those trainings that there's a lot of emphasis on One Health and on inclusion of animal health experts in the investigation team. But the reason we were doing the training in the first place is because we were increasingly concerned of what has always been described as a zoonotic emerging disease, but in reality was becoming more and more common and longer chains of human to human transmission. So we were already seeing the writing on the wall with the fact that there were cases of monkeypox exported to other countries. When the United Kingdom reported a case on the 7th of May this year, it was the 10th documented exported case of monkeypox from West Africa. So as I say, we were beginning to understand that those documented exported cases were just the tip of the iceberg, that there were probably other exportation events of people carrying virus as they travel. And these could be people traveling to a location, people traveling from a location. The point is that travel makes this all easier. Yep. You go from place A to place B, you bring your virus back with you, and so the suspicion was already growing that there were probably many more events of this nature that did not come to the attention of health services, perhaps because people had their rash, but in fact, as in many cases, it's a self-limiting condition, then perhaps they resolved their rash without needing to seek medical care. Those that did come forward were seeking medical care because they had pain, itchiness, severe, quite ill, some of them, severe illness, or like, for example, whether it's fever or really large areas of the body covered by rash. And so some people can become quite ill. We're talking about monkeypox now, but some people can become quite ill while others experience a lesser self-limiting disease and may not come forward to health services at all, which is one of the challenges we're beginning to face now in the outbreak response. But in terms of, the history of monkeypox as a disease and the evolution of that history from the first identification in an animal, which happened to be a monkey, realization that in fact it transmits in rodents primarily, but also through access to the forests and the zoonotic spillover through hunting and bushmeat and that type of activity. Then extending chains of transmission because of waning immunity globally. And then we have a similar phenomenon that occurs in West Africa, where with a different clade, we're seeing more and more human-to-human transmission, including exportation to non-endemic countries or countries that had not previously experienced monkeypox. And we haven't talked about the 2003 outbreak in the United States yet, but that one's a bit different. And here we are today. That this evolution, it really is quite the story. You can see how it has evolved from 1958 to where we are today.
Absolutely. Appreciate you walking us through that story. It's fascinating. Rosamund, one of the, as I mentioned in the intro, one of your responsibilities on the COVID team was for the management of so-called infodemics, and this is something you've also been publishing about recently. A couple papers in the WHO Infodemiology conference paper. You define an infodemic as an overflow of information of varying quality that surges across digital and physical environments during an acute public health event. It leads to confusion, risk-taking, and behaviors that can harm health and lead to erosion of the trust of health authorities and public health responses. And then in another paper, Infodemics, a New Challenge for Public Health, you then go further to dissect these different dimensions, highlighting agent, medium, time scale, network, and control measures for infodemics. Could you say a couple words about obviously, the last couple of years, we've been in a major infodemic alongside a pandemic, but have there been other infodemics that, we might be less aware of, just from the perspective of the lay people that, don't think about these things all the time, but please talk about infodemiology in general, if you would, and what you've been up to.
Well, infodemics, there are in different spheres. We're talking about the health sphere, but of course they exist in the political sphere. They exist in many spheres, right? So whatever you choose to call it, attributes, well, there's different types of, false information. So it could be misinformation, which may or may not be deliberate. And so people may inadvertently transmit news. This is exciting news, let me share it with my friends, only to find out later that in fact it wasn't correct or accurate or a good representation or a balanced view of a situation. And then you have disinformation, which is, for whatever reasons, deliberate misrepresentation of information or clearly just false information. So the term fake news is very catchy and has been used to cover many of these things. But part of it is simply, just like with everything else in our world today, things just travel very quickly. Just the same way a virus can get on a plane and hop over to another continent, information travels on the internet even faster than that. So whether it's good information, incomplete information, not good information, false information, it seems to travel very quickly, and the false information often is accompanied by appeals to emotion, for example. And so people respond to things that appeal to different emotions, whether it's anger or whether it's, they try to incite anger at a certain entity. Directing anger at authorities, for example, is one way of doing this. Anything that is clickbait, anything that is, looks catchy, it looks, well, hey, this looks interesting, let me click on that. Or I think we've all found ourselves in the situation where we want to share something. And actually, I was very pleased recently when Twitter said to me, would you like to read that article before sharing it? And I'm like, oh yeah, I guess I'd better. I mean, it's like, so we can all be caught out this way, that of just sharing information without necessarily fully understanding its import, or simply that the interpretation that someone else has put on it may not even be the interpretation that you would put on it if you read the information yourself. And so that, so whether it's about the origin of a virus, or whether it's about some of the countermeasures, vaccine, of course, a very touchy subject, whether it's about policies that governments decide to put in place or decide to not put in place. And people come to any question of information with their own perspective. And so if you already have a belief in a certain set of beliefs, it's much harder to change that set of beliefs, and rightly or wrongly. And one of the things that social media does is it pulls you down a rabbit hole, right? So that if you click frequently on a certain type of information, the algorithms behind some of the social media platforms will say, oh, this person likes this kind of information, let me offer up more of the same kind. And then, there's far fewer algorithms that will say, oh, this person likes this information, let me offer something that says the complete opposite. They're not going to get the time spent online, which is what social media companies need you to do, is to spend more time online, spend more time on their site, spend more time using their app, many of which are, funded by advertisements, of course. And so the more time you spend on their site, and so they want to give you information that you like to read, that you want to read more about. But this means that we create echo chambers, what have been termed echo chambers, where you end up in a conversation with people who think the same as you, and increasingly so that less and less frequently you might hear an alternative point of view. And by hear, I also mean see, experience, little videos, whatever it is that is being put out there to catch your attention. And so the challenge of health authorities is, even at the local level or the national level or the global level, is to put out information that is as balanced, that is accurate based on the science to date, which also changes. And sometimes that's hard to really appreciate how much the science can appear to change in a rapidly evolving situation, as you referred to earlier. And then, so trying to stay on top of this for health authorities requires a lot of expertise in communications. It's not only the science expertise and the public health expertise, but you need communicators, you need animators, you need resources to outsource to companies who will help you design catchy materials, and it costs money and it takes time, and you're constantly, I don't like to characterize it as a battle, but you're constantly trying to put information out there to counteract what other people may advertently or inadvertently be sharing that is not quite perhaps science-based or evidence-based as health authorities prefer to do. But even health authorities need to appeal to emotions in the sense of a sense of dignity, fighting stigma. And so if the messaging coming from health authorities is perceived to be demeaning in any way or dumbing down or contributing to stigma, then people will also run away from that information. So the challenge we have, and I don't know if you want to talk about the monkeypox outbreak just yet, but I'll just throw this in here as part of the infodemic discussion.
Please, please.
One of the challenges we have is that when we talk about monkeypox today on the, in July 2022, we're talking about everything that I've just described of the history of the disease and its evolution over time. But since May of this year, we have a very different situation, which we have an outbreak which is spreading primarily among men who have sex with men. And for the information that we have today, to more than 2 months in, that is still 98% of the cases, almost 99% of the cases. So now we find ourselves in a situation where we do Epi 101. You asked what interested, how I got interested in epidemiology. Right. Epi 101 says, describe an outbreak by person, place, and time. Right? So you want to describe who, the person, what type of person, what characteristics they have, what is their behavior, what is their context, their circumstances. So that's the person. You need to describe that, because in describing that, you describe how, who is infected and therefore who's at risk. Right. Then the place is, where is this happening? But place can also be a very broad concept. Is it happening in Africa, or is it happening in a place where it's never happened before, which is what we're seeing now? Is it happening in certain settings? Is it happening, which we discussed in COVID extensively, the settings where, which were closed, confined, unventilated settings. So here also in monkeypox, what are the settings in which this is transmitting? And then time, the time is, what are the cases happening over time? And clearly we're seeing an evolution of this outbreak over time. But the very first thing you want to know in Epi 101 is this a point source? Is there something that has triggered, like your classic, salad at the church supper, where everybody gets salmonella at the same time because they all ate from the same salad bowl? That's called a point source infection. Yeah. Or you have person-to-person transmission, which means you go through the incubation period, the infectious period, you transmit to another person who goes through the incubation, the infectious period. And so you see waves of, you might see waves of cases over time as transmission, as spread occurs through, different extended transmission chains. So you might have a combination of these things, which is extended person-to-person transmission, but complicated by periodic outbreaks due to a point source event, where for COVID, we termed these like super spreader events. Right. For monkeypox, we're preferring the term amplifier events, only so that people don't get confused. Again, it's about information, right? Sure. People don't get confused between monkeypox and COVID. So we're trying to just use information that says the same thing, but that says we're talking about this disease now called monkeypox. So we have amplifier events that have occurred, that continue to occur, and how to message that, how to share with people the circumstances in which they would put themselves at risk, and how to reduce their own risk, and how to protect themselves and how to protect others. Our primary population that we want to reach right now are men who have sex with men. Not all men who have sex with men, but men who have sex with men who may have frequent encounters, possibly multiple partners, possibly anonymous or new partners. And this is the group at highest risk right now. Now, how do we do that without stigmatizing that group? Right. And how do we do that even with all good intentions, which we must do, without being accused of stigmatizing that group, right? We don't want to stigmatize that group. It's a group that are very proactive in health-seeking behavior, by the way. Mm-hmm. They want the information. This is what we're given to understand. And even the language we use is language which has been discussed with representatives of MSM groups. They advise our communicators on what is their preferred language. What are terms that are okay to use? What are terms that we should stay away from, and things like that, so that they can help support, whether it's the World Health Organization or any other public health agency. It's really community engagement is critical. Engaging the communities that are affected is critical to good risk communication, which is the skill set, if you will, of the activity of sharing information that will allow people to appreciate their own risk, reduce their own risk, protect themselves, make good decisions, and protect other people. That's risk communication. And so much of what we do in infodemic management, infodemic response, is to try and we do monitor social media, and we find out what people are saying on Twitter, Facebook, TikTok, and all the others. That is monitored, so we understand the conversations that are happening. However, our response to that is risk communication and community engagement.
Yeah, it's fascinating, and thinking of the balancing, the multiple responsibilities you have is just is so impressive in terms of managing not just the biologic but the information side of this. And it's quite fascinating, Rosamund. While we're on the information, I have to ask you one thing here, and I know going a little bit outside of infectious diseases, but I have 3 kids in this house here. Well, not really kids anymore, but 20, 18, and 16, and they turned out pretty okay. But there was, a period of time there with all these weird social media things coming online that my wife and I were staring at each other for a while, and keeping our fingers crossed. Can we just spend a couple of minutes on your 2015 paper about frequent use of social networking sites and poor psychological functioning among children and adolescents? And I have, my eldest son he's going to his sophomore year in college, and he's going into psychology. And we always have the discussion, you have a lot of kids out there in 10 years from now, you'll need some counseling. Talk a little bit about this paper, if you would.
Right. Well, when that paper was written and published, my son was 11 and now he's 18. So
same schedule.
And there's an older one as well. So I've also gone through that same, I showed my eldest child this paper and I sent it, and I just sent it. That's all at some point. And they responded that, oh, this is such a fascinating paper. This is so great. And hadn't even noticed that I was one of the co-authors. So it's good. It's good that someone found that this was a good paper. In fact, that was a collaboration. It was the initiative of my co-author at the time at Ottawa Public Health. He had databases of studies that had been done in school children, and this is something that in Ontario is done on a fairly regular basis. I can't quite recall if that was municipal or a provincial study, but they had access. That was municipal. Yeah. Okay, thanks. So they had access to this database of questions that had been posed to students, to pupils. And so, he was just looking at this database and wanted to pull out some of this information. And this is where the epidemiology skill set comes in, because this was a study at one point in time. So it's what's called a cross-sectional study. You go into a school, for example, and you give this questionnaire, and probably, I can't recall if it was done with, by the students themselves or whether the parents helped them fill it out. But in any case, the questionnaire is filled out at one point in time. So at one point in time, you might ask questions like, how much sleep do you get at night? How much time do you spend on video screens? And also, oh, by the way, how do you feel? Have you ever had any bad thoughts about yourself? And so the questions that would be targeted to worded for an appropriate age group, but they're all asked at one point in time. So then you pull out an association, and it's, association and correlation are not causation. That's another one of the primary tenets of epidemiology, that you might find an association between things. It doesn't mean that one causes the other, right? So what was critical about that paper was to say, oh, we found an association. This is really important. Are people spending time online because they're depressed? Or are kids getting depressed because they're spending too much time online? You know, so it's a chicken and egg thing. And in a cross-sectional study, you can't really answer that question. What you can do is you can hypothesize, and you can also propose solutions. So, whatever you hypothesize in that paper, I think we may have articulated different hypotheses and said that this paper can't answer this question. Therefore, always what the scientists say is more research is needed, right? So, there's always more research to be done and more research is needed. And in fact, a lot of people have cited that paper as they have continued to do research on the topic. But the other thing that we were able to discuss in coming out of reviewing that paper was, well, anyway, since these kids are spending so much time online, how can we as a public health agency promote access to good information online? So that we see it more and more now, of course, with COVID and major platforms collaborating with WHO and other health agencies in promoting and prioritizing the showing of public health information. At that time, that wasn't really, I'm not sure that was happening to the same extent. And so one of the things that we recommended from that paper was that maybe health agencies should consider this, should consider using social media more to provide good information, so that if the kids are on there anyway, you can provide age-adapted, good communication about, do they need help, and where they can find it. If it's just a local message, that's enough. Kids helplines, a website they could look at if they were interested, but also for school authorities. So those are some of the interesting things that came out of that cross-sectional paper, from which we could not establish causation, but it didn't stop us from thinking about what are some of the other things we could do and some suggestions we could make.
Absolutely. Yeah, that's it. As I said, I was going through PubMed, and that one popped out at me. I was like, wow, she really wears many hats, and so yeah, thank you. I appreciate you taking the time to talk about that one as well, because I think that one's going to pop up more and more in the future as a theme. So, Rosamund, I know we're coming up against a hard stop for you. You have to go do other things, but while I have you, anything else that we should know about in terms of the Secretariat, conferences you're going to be speaking at, upcoming talks, any place we can see you, meet you? Please take the floor if I missed anything critical to the next few months of what's going on with you.
Well, I think for me, the next few months are going to be primarily continuing with, as technical lead for this outbreak response.
Right.
We are having another emergency committee meeting next week. I'm not sure when this is going to be aired, so I'm not sure, but that is scheduled for the 21st of July, and we will receive advice and guidance again from the emergency committee on how to carry this forward. Clearly, what has become evident, as I mentioned earlier, is that the outbreak itself wears many hats. Since that's, it has the original hat of Central African monkeypox. It has the West Africa hat, where person-to-person transmission has probably been occurring a lot more than was previously realized, and now it has the global multi-country outbreak hat, where very few persons are yet being infected outside the group of men who have sex with men. And so working with festival organizers, pride organizers, mass gatherings, venues, working with associations, sex worker rights groups, whatever group that we can work with. This is, at the moment, it's not exclusively an information response, but it's a very predominant component of this response, is getting the right information to the right people at the right way, at the right time, in the right way, so they can protect themselves and others, and avoiding stigma. So this is really critical, because in my view, the window might be closing very quickly, and I'm concerned about that. But while the infection remains almost exclusively among men who have sex with men, and that's not to say that others can't become infected. Anyone can be infected with monkeypox, and this is part of the challenges of messaging this. It's not, there's no reason that others can't be infected if they're in close physical contact with someone who has a case. But while the infection is spreading primarily in men who have sex with men, who are very proactive in health-seeking behavior and do want to access testing and do want to access vaccines and do want to access therapeutics if they need them, if they're ill enough to need them, then we still have a chance to stop this outbreak. We still have a chance to stop that component of the outbreak. And we're working, I think we're going to be working very hard on that aspect of it. But I think there's a really strong lesson learned here is that it doesn't pay to neglect diseases just because they're occurring on a different continent or in a different setting or in a different population. And we will absolutely not be able to neglect monkeypox going forward, even if we succeed in stopping this outbreak, this global multi-country outbreak. So then the work will need to continue on diagnostics, vaccines, therapeutics, and supporting countries, who have this virus in the animal population and therefore will not be able to eliminate it completely. The other challenge that we have, and it remains around information, communication, human rights, stigma, even laws, national laws, is that in some places, people obviously don't want to come out as participating in certain behaviors, or being homosexual may actually be illegal and may cause personal safety, threat to their personal safety, possibly imprisonment, possibly even loss of life, and violence. And so it becomes even more challenging for my colleagues in the WHO regional offices and in the countries in the regions of Eastern Mediterranean, Africa, and certain parts of the world where it's not okay to be perceived to be a member, to be someone who's part of this group of men who have sex with men. And so, getting the information to them, making sure they have access to services is even more challenging, because what we think is that there's underreporting, of course.
Sure.
People are either afraid to come forward, or they might see a physician but don't want to be tested, or access to testing may simply not be available yet where they are. And so we work on all aspects of it, as you said. We work on the information, we work on access to testing, we work on improving information around vaccines and therapeutics, while also improving efforts to make them available where they can be used. And these are all critical elements. And as you say, because there's so many different things to be done, it makes it very interesting from a professional perspective as well.
Absolutely. And it's an amazing story, and I'm so glad you're there leading it, because it is such a critical domain of what's going on in health security around the world nowadays. So rooting you on in continuing and what you're doing, and continuing to watch you lead this effort. Again, for everybody that is going to be listening to this episode of the show across the various podcast networks, or watching on the YouTube channel, you've been listening to Dr. Rosamund Lewis, World Health Organization, head of the Smallpox Secretariat, Emerging Diseases and Zoonosis Unit, World Health Emergencies Program there in Geneva, Switzerland, also adjunct professor, School of Epidemiology and Public Health, University of Ottawa. Rosamund, I want to thank you for taking the time out of your schedule to come talk to us for a while about these important topics. Obviously, thank you for everything you're doing. And as we say on this show, thanks for helping to create a better tomorrow for many people via what you're doing. It's a really wonderful story.
Well, thank you so much for your interest. It's been a real pleasure to chat with you.
And
thank you for what you're doing too.
Be well.
Thanks.